Good morning, everybody. Welcome to Grand Rounds in December. I'm very happy today to introduce Dr. Jacqueline Linnes. I am the Vice Chair for Education in the Department of Medicine and happy to see everybody here today. Dr. Linnes is the Marta E. Gross Associate Professor of Biomedical Engineering at Purdue University. Her work emphasizes the application of fundamental microfluidic principles and biologic assays to develop point-of-care diagnostics for global health and wearable devices that enable health disparities research. She has co-developed mobile diagnostics, wearable devices, airborne pathogen inactivation tools, and water purification technologies with users in the US, Nicaragua, Kenya, Zambia, and Haiti. As a result of her work, she has authored many high-impact, peer-reviewed publications, 2 book chapters, and she has conducted workshops across 5 continents. She has been awarded 7 patents and formed 3 startup companies based on the lab's developed technology. Prior to joining Purdue as faculty, Dr. Linnes earned her BS in engineering from Purdue University and her PhD in bioengineering at the University of Washington. Dr. Linnes has received numerous awards for her work, including a fellowship in the Executive Leadership in Academic Technology, Engineering, and Science, and several consecutive awards at Purdue University as the most impactful faculty inventor of the year. Welcome, Dr. Linnes.
There we go. Thank you. I really appreciate the invitation to Grand Rounds. I hope to come in person one of these days, but for now, I am joining from Purdue University. I am looking forward to telling you a bit about the type of work we do, making widgets and technologies for extreme points of care that we think of. There we go. Come on. Purdue is just a little ways away, only a couple of hours for you all, but as I do global health, I always try and demonstrate we are a little bit greener than you right now. It's not snowing too much. We had some snow earlier, but it's beautiful and sunny right now, just south and a couple hours south of Chicago. My lab focuses on developing various technologies for community-based testing. And we do this using a human-centered design approach, which means that we're actually going out into the communities and finding out what the needs are, what are the constraints, what are the challenges that are being faced, and we try and build to the stakeholder needs, which is how we teach engineers to do this in all of our undergraduate courses, but in reality, things get fuzzier. People tend to focus on the technology itself and forget about the people using it. So we're trying to bring that back. That has led us to different devices that are focused around nucleic acid based in many cases. So paper-based test for HIV that I'm going to talk about today up in that top corner. We've developed some smartphone based technologies that we actually just took to Kenya for viral load monitoring beginning of November, actually, as well as some work in paper fluidic detection of cervical cancer and proteins as that's progressing in places that you couldn't necessarily do a pap smear and get results in a timely manner. And some newer work in wearable biosensors, cortisol monitoring for depression treatments. We go develop the technology based on the needs. So first we go find out what are the constraints, and then we build to spec. So you'll see lots of different types of technologies in these examples. But first, I mentioned that a lot of engineering is technology centered. Which we're trying to flip. When I started my lab back in 2015, I really wanted to think about the users and what their needs were and what those feasibilities are. I have since grown to work with more individuals in public health, and they've taught me about human-centered design and what it takes to actually adopt the technology, and now even equity-centered Who is not able to use this, and how do we build specifically for the people that don't otherwise have access and make sure that they can have access to? As we think about this, we're thinking about engineering diagnostic technologies for social good. That means, what assay do we want to detect? What platform do we use? And will anyone be able to use it? And how do we make sure it's used correctly? We started this around an HIV project funded by the Gates Foundation, specifically looking at how can we get more people aware of their HIV status. The UN AIDS goals for 2030 were 95% of people aware, 95% of those people into care, and 95% of people in care who are achieving viral suppression. The US is nowhere near meeting that. The world is not either. But in the US, only 84% of people who have HIV are aware of their status. And so it gets worse from there, but that's the space where we're targeting. And we're looking at this from the needs of experts who said we need to deploy a comprehensive strategy with novel approaches to testing. And that means that we can't just wait for people to come to hospitals. Unfortunately, I was just in a hospital helping take care of my dad who had sepsis, and it's very clear that the sickest individuals come to hospitals. If we want to get people before that, we need to take things to other access points, to clinics, and in our case, to these extreme points of care where we are going and taking technologies to the people. So to individuals in syringe services programs, to people experiencing homelessness in shelters, to community outreach events. And that means that we need technologies that are accurate and affordable and accessible. And there will be trade-offs to be able to meet all of those capabilities. We don't have centralized labs that the hospital lab has, which means that you can't do all of the capabilities, but what are the specific things that are needed on site? So if you think about those, some of the most accessible technologies that are out in the world are glucose meters, pregnancy tests, COVID tests these days, and thinking about those in the pregnancy test space, you can actually get a test that is both high concentration and low concentration of HCG. When you open up one of these, there's 2 test strips. There's digital ones that tell you how pregnant you are, how far along you are. After 2 kids, I know that that isn't necessarily the most important thing. Plus or minus 3 weeks was up to them, not me. Both of them were early. But the really interesting engineering side of this, if you look at this digital pregnancy test, is that here you can see, based on those concentrations, how far, if it had been 2 or 3 weeks. But this test has semi-quantitative results, and it has more processing power than the Hubble telescope did when it was put up in the 80s now. So we can do a lot with the level of technology that we used to have to launch into space that we now pee on and throw away. There's lots of sustainability questions about that, and we are thinking about those as well. But what we're thinking about in particular is, with this amount of power, what can we be doing and bringing incredible technologies to the individuals that might need them. So for those who have used lateral flow tests or these rapid diagnostic tests, as I mentioned, pregnancy tests, COVID tests, HIV, antibody detection, the way that these run is actually quite a lot of material science and engineering that has gone into them. Your blood sample or urine sample or saliva or nasal swab has your target of interest. For example, in HIV, that would be P24 antigens. Those flow downstream and bind to the antibodies that are attached to gold nanoparticles, which are red at the tiny size that they are. A whole bunch of nanoparticles continue to flow downstream, they bind to an antibody on the other side, and they all pile up on that test, giving you a red line. Anything excess binds to the downstream test line, which is the control for flow. And as we've seen, 2 lines is yes, and 1 line is no. The challenge is, why wouldn't we just use an existing rapid diagnostic test for HIV? And the issue is that the antigen-based tests that we use for COVID, that we use for pregnancy, that we use for malaria, require really high concentrations or comparatively high concentrations of the target to be able to detect it. The way that we test for HIV is that we test for host antibodies initially, although there are some newer antigen tests coming out. So what happens then is that when you're when you have an exposure event, you have up to 2 weeks for the virus in your body to be producing a lot of virus until the lab is able to detect even that viral RNA for HIV. A little bit later, you can detect that P24 antigen in the lab and at 16 days. And then in theory, the 4th generation rapid tests for P24 can detect as early as 1 month. But if you have to wait until the antibodies, you have to wait until 90 days, because that's how long it takes for your body to fight this virus and to produce the antibodies against it, given that it is attacking the immune system. Unfortunately, clinical sensitivity for these rapid tests, not the lab tests, but the rapid tests, is really poor. Back in 2018, they did a test of 300 different samples for these, all the way up to 5 million copies of virus per milliliter. And the ideal test would be able to detect femtograms of this protein. The manufacturers all claimed it could do low picograms, but in reality, not a single thing was detected with these 4th generation rapid tests. Now, I will say that in the last 5 years, they have gotten a bit better. They are able to detect some cases earlier than waiting for the antibody, but it's still not enough to be able to use the antigen on its own as a rapid test. So we have turned to alternatives as we've compared these protein-based rapid tests that are affordable and accessible, but not as accurate, with nucleic acid tests, which are accurate, but not affordable in the same way, and not as accessible. You can't take these toaster-sized boxes and move them around. They require recalibration every time. So our goal has been to combine the accessibility and the affordability of paper-based rapid tests with the accuracy of nucleic acid tests. We've done this in a couple different ways. We have developed controlled fluid flow along the paper, because if you've ever spilled coffee or anything, you know that you can absorb it with paper, towels and whatnot, but you can't control how slow or fast it picks it up. So we've developed valves to start and stop fluid flow along the way, as well as separating the virus from the red blood cells, amplifying it, and then flowing it downstream for detection in what is as easy to read as a rapid test. In 2019, we got this whole thing put together. Lots of members of the lab contributed from many different angles, from molecular biology to electrical engineering to materials. We had folks from all over coming together for this. One of the core aspects is that we use something called loop-mediated isothermal amplification of nucleic acids, or LAMP. And what that is it's an alternative to PCR. And so both of them make billions of copies of your target nucleic acid. But PCR requires more purification and nucleic acid extraction, whereas LAMP can be with a cruder sample. The equipment for PCR requires very controlled temperature cycling, up to 95 degrees and back down to 55, 70 many times, which means that the amplification time can be a bit longer with that cyclic temperature. But the primer design is pretty easy. You just need a front and a back to target that sequence of interest. LAMP can do this all at a single temperature, 60 to 65 degrees. You hold it steady, and the polymerases are able to create billions of copies. The challenge is that in order to do this, you need primers that loop over on themselves. And that design is a bit more complicated, although there's some open source opportunities to be able to design them. And it's a little bit of guess and check. But when you're done, you get your 10 to the 9th copies of your target. And you can tag these, as we have done, with fluorescein and biotin on either end. And the reason that we do this is because we can use that in the lateral flow strip or the rapid diagnostic test type readout. So that way, the nanoparticles bind to one end, they flow downstream and capture with these antibodies. Now, the challenge with that, well, the advantage is that we get 2 lines yes, 1 line no. The challenge is controlling all of that extramolecular biology in that easy looking readout. So the first thing we did was work on fluidic control. As I mentioned, starting and stopping fluid in paper. The way that we did this is we had printed wax on top of the paper, and we used a technique that others have where you heat it, and that causes the wax to melt into the paper, and it can stop the fluid flow. And so here you can see on the right side, you can stop the fluid. Underneath, if you heat it again, then it melts and that fluid is able to go past. So we can create a valve that tells the liquid when to stop and when to go. And we did this initially demonstrating that you could use some commercial heaters underneath, and when you added voltage, they heat up, and then the wax is able to flow in different stages. We also did this with some printed silver ink resistors that had a lower power requirement and meant that we could use a USB or a AA battery to run it. And the advantage of these is that we could design them in different ways so that we could have one that holds the temperature at our 65 degrees for LAMP, and another that spikes the temperature up for melting our wax valves, which melt at about 80 degrees, so they don't accidentally have any opening before we want them to. You can see on the right side in that very bright spot with red, yellow, and then out to blue, you can get the maximum temperature up to 105 degrees with these with these heaters, which is fantastic, but it burns our paper, so we don't do that very often. The other aspect that we definitely underestimated initially was what it would take for the electronic controls. And so I had a very astute graduate student, Dr. Hoylett, who is now running his own lab at the University of Cincinnati, where they work on specifically electronic aspects of medical devices. But this included temperature sensors in order to know what temperature we had the valves at, and a microcontroller that we use that has the brains, and then a USB power harvester so that we can pull from any power source, whether it's a battery pack or a phone, or plug it into a computer, whatever we might need. We got this done in, as I mentioned, 2019. The user steps is what we had originally been focusing on, is how do we make this as easy as possible for the user? So for the user, they add their sample in red there from the collected blood. They add some wash buffer behind it. They close it up, and then as soon as they plug it in, it starts to heat. They wait for the amount of time it takes for the whole process to run, and then they can look for 2 lines yes, 1 line no. It doesn't interrupt their workflow with timed steps that they might otherwise need. And ultimately, we were able to show that we could detect HIV from whole blood using this. On the right side, we've got our positive, on the left, positive followed by the negative. And then we show that the line intensity is much stronger in the test line, where you can see the two lines, than in when we have a positive result than in the negative result where there's only one line. We were really excited about this. We got it published. We called it a success, but we wanted to take it further. And we wanted to take it further because a lot of things get published and then nothing happens to them. So we thought about this. We gave it to our collaborator, Dr. Eddie Odari in Kenya, at Jomo Kenyatta University of Agriculture and Technology, and he's been helping us with the assay designs and everything else. And we ended up troubleshooting via WhatsApp. And you can see some of the processes. He says, today, the low positive control had results within an hour, but they came up one line, which would be negative. Only the control line generated, but at least it ran, so that was good. But maybe it wasn't sensitive enough to detect that. So we looked at the concentration, and we know the limit of detection wasn't as good as the laboratory. So we had him run the higher concentration, which was 420,000 copies per milliliter, which is a lot of virus. And unfortunately, that did not work either. So it is below the limit of detection that we had tested. So what we needed to figure out is what happened. Did this not work because we didn't develop a sensitive enough test? Did it not work because it sat on a bench and took an airplane across the Atlantic and then hung out in Dr. Odari's lab for a few months before it ever got tested and some of the enzymes died? We don't know. And we didn't include a control to be able to find that out. So we went back and we thought about our core aspects of the assay, the platform, and the design. So we went through a few different processes. So on the assay side, we want to include an internal control that says, yes, the test ran, but it truly is negative. On the manufacturing side, we realized some aspects that we needed there. But first, we wanted to go back directly to the human and equity-centered design and think about where are the places that we need this to run and what are their clinical needs as they're going through this. So we thought through the human-centered design process with the Health Equity Lab here at Purdue. And we thought about understanding the specific context of use again, designing for that, prototyping again, getting the user feedback, and then iterating on that. And in that process, community and stakeholder engagement is absolutely essential. If we want people to not only use it properly, but adopt this, we need to understand what is the context that it's being used in. And we need to engage and listen with those individuals. So I have two students that are co-advised by Dr. Rodriguez and have done quite a bit of shadowing in community clinics, in syringe services programs, in the local shelters here, to understand what are their needs. And then they've also been able to interview clinicians, clients, and other community health workers in the process to see what is happening. And that is just so that we're not taking all of our technologies and chucking them into a garbage pit while patients are waiting on the other side. We first did this in 2020, which had its own challenges. We used a socioecological model to guide 15 interviews of HIV and AIDS service organizations. Right now, they send blood out to a central lab for testing, and they wait to get the results back for all the clients. So yes, they thought that it would be worth a 1-hour point of care HIV test because of the amount of counseling that's already done, and when they could do the testing, they felt that it would be reasonable. We also asked them about some of the innovations and challenges that they faced during COVID-19. And obviously there's a much higher risk perception, and mental health conditions are exacerbated. At the organization level, they implemented for COVID-19 self-swab testing and self-sampling, outdoor testing and physical barriers. And what this means is that if we were designing only for the individuals on the healthcare side, then we would be designing our test for people who are taking the samples from someone else, as opposed to the self-sampling that we ultimately did for COVID. And so that changes who the user is and what their needs are. And further, when they were collaborating with jails and correctional facilities, which they hadn't done in the past, they actually would send the kits to those correctional facilities and do virtual instructions and education, which means that we could include virtual instructions, but also our users are 2 steps away from the healthcare provider that they were planning on, that we were thinking we were designing for. So not only do we need to design for patients and clients themselves, we also need to design for correctional facilities that would have a whole different set of training and different requirements and needs. So this helped us think more broadly about the types of requirements and needs in our device design and who does it need to work for. And so as we did that, we went back to our assay improvements, and 2 of the graduate students have done a lot of work on this. Both graduated, Dr. Suchong and Dr. Nwanochi now. They worked on an internal amplification control. So this means that it would have improved clinical utility. We would be able to say that if you're detecting 18S human rRNA, you know that you have a human sample. For blood and HIV, this isn't as big of an issue because you can see the blood on the pad in a bright red spot. But for SARS-CoV-2, which our lab, as many labs in diagnostics, turn towards, you can't tell if the swab was taken correctly. And the advantage of doing this 18S rRNA was that not only is the sample done correctly, but also the entire assay has to function, and all of the proteins have to be intact and stored successfully in order to get that test line. And so that control showed up in this case as we detected various concentrations of SARS-CoV-2. You can see that the flow control always shows up, which means the nanoparticles went where they were supposed to, but also that internal control always shows up, which means that we always had the saliva that we thought we did. And the SARS-CoV-2 line only shows up when we have the virus. We then did some clinical sample validation with 30 retrospective samples from collaborators at the IU School of Medicine who provided these. And we compared to the RT-PCR positive standard and our duplex RT-LAMP, where we had both of the control RNA and the saliva tests being done at the same time. So for that, it had to be less than 37 cycles for PCR to be positive and 3 lines on our lateral flow. And we compared true positives, true negatives, any false positives that we had where ours said there was virus and there wasn't, and any false negatives where ours said there wasn't virus and there was. And for that, out of these 30 samples, 20 were true positive. We had 1 false negative, and we looked at it was a very low concentration of the virus, and then 9 true negatives. So that gave us a 95% sensitivity and 100% specificity, which is where it needs to be, at least at the time for the EUA emergency use authorizations by the FDA. It needed to be at least 80% sensitive. So we were happy with that, and we're moving forward with keeping that internal control in all of our tests. The other aspect that I want to highlight is the valve reproducibility and flow. So that our valves for the wax mostly worked when we worked with Dr. Odari and sent them. There was 1 failure, and we didn't know why. So we investigated that. And we also looked at maybe we can speed up the process. So we designed and modeled some that were printed straight, some that were printed with these concave shapes, and some that were printed in convex. And we did see a bit of a difference in time to open. These convex ones that are little oval shaped opened faster, but they actually flowed more slowly. And so we measured this over time, every 30 seconds, where the front of the liquid was. And we did a computational model of this as well in MATLAB. And what we found is that actually, ultimately, when we wanted to detect how strong the signal was, none of the valve shapes made too big of a difference. They were slightly better with the convex, but we thought we could predict it, and it turns out we couldn't. So we went and looked at the smaller scale. We wanted to understand at the materials level what is going on. So this is a picture of a scanning electron microscope of nitrocellulose, which is the material that the lines are printed on. And this is plain nitrocellulose. And then we put nanoparticles in that were 100 nanometers, which is a little bit bigger than the gold that we used, but was visible under a microscope. And here, the flow is going from top to bottom of the liquid, and the nanoparticles are following along. But some of them you can see are stopped or moving very slowly, and others are moving very quickly. And in fluid mechanics theory, there shouldn't be a difference. Everything should be going at the same speed if this was what we expected at the bulk flow. So what we found as we quantified this is that 10 millimeters downstream, 15 millimeters, and 20 millimeters, you can measure the flow rates of these particles and look at how fast they're moving. And instead of moving from fast to slow, as we would expect, based on how far away they're going from the source, they actually, some of them, not many, but some of them were going really fast, much further downstream. And so this means that everything we think about our kinetics and the amount of time available for those nanoparticles to bind to antibodies on a surface is actually much more complicated than what we thought was happening just from the bulk flow. And so it doesn't represent the individual particles. And that gives us, this visualization gives us a whole new tool that we can look at those local phenomena. We can look at the valve opening, we can try and understand binding kinetics, we can look at more complicated tests that can allow for increased signal amplification and try and understand where the fluid flow is going in there, and try and do a little bit more smart design of these lateral flow tests, which are very much done even in the broader industry in a very empirical manner, where you just take a lot of different conditions, run them, and compare them. Maybe we can be doing this more smartly and understand some of the modeling side before we throw them into buying many expensive antibodies to test and compare. One aspect of this that we think is really cool is that this visualization isn't just for fluid flow in paper. We started a project on particle diffusometry to quantify the nucleic acid amplification. And this started a bit in parallel in that we had this idea that we could image particles and watch their motion in a smartphone even. And so this smartphone on the left started as an undergraduate senior design project where they were taking the visualization from a $200,000 microscope and putting it under a smartphone with a little laser pointer and a tiny optical microscope that they could use. The iPhone 6 at the time, which was state of the art, and now you have to buy on eBay. But we could use that. What we learned over the years of trying to start a company around this was that smartphones change really quickly. Cameras on those phones change, the optics change, and so we actually developed a solution that doesn't use a phone at all, but can connect to one. And that was through OmniVis, which is no longer in existence, unfortunately. I'm happy to talk about challenges of getting startups off the ground, but that's no longer a conflict of interest as of this last summer. But we got a lot of work done, and it made a lot of progress, and learned a lot about getting things out of the lab and into the world. The view from the phone is using this little ball lens as a microscope, a little metal plate to hold it, and a blue laser diode. These 400 nanometer particles in there are wobbling around. Let me see if I can get them to move. There we go. And so this is just in any quiescent solution, you will see particle motion. And this Brownian motion, as it was defined, can be quantified using the Stokes-Einstein equation. And that diffusivity, or D, is related to the Boltzmann's constant, the absolute temperature, the dynamic viscosity of the solution, and the hydrodynamic radius of the particles. So if we can control temperature and radius of particles, we can tell what's happening in the solution viscosity just by looking at these particles. And that's what we have been using. This particle diffusometry measures different images over time, correlates the particle locations, and then you can back calculate that diffusivity from the known magnification and the time steps in there. What this allows us to do is do things like measure hydrogel formation over time. And so when we make a polyacrylamide hydrogel, the particles are wobbling around in the monomer solution. And at that center, you can see that they've stopped moving as that circle spreads out and a hydrogel forms. And so that is the changing and the reduction of viscosity over time. And in the center of that circle, those particles no longer move. If you did a time lapse, it makes this cool starburst. But the important quantifiable part is the change in diffusion over time. And at different cross-linker concentrations, you can see that slows down, which means that we can actually quantify and back calculate what was that initiator concentration and how did that affect the hydrogel. This is exciting because we can do that not only for hydrogels, but we can do that during our lamp amplification process. As you produce lamp amplicons, they're very long and they are their own polymers that are forming. And they're cross-linking and getting attached to each other, and the particles get unable to move around nearly as easily. And we can quantify that process as we amplify HIV in this smartphone type device. And over on the right side, you can see the change in diffusion based on the concentration of the viral particles in there. And then we did some more back calculating to how long it took to reduce that to the threshold. And then on the right side is the change in diffusion coefficient based on the copy numbers over time. And this gives us a semi-quantitative way to measure HIV viral load. And I just last month was in Kenya, and we were testing this out with our collaborators at Moi University there. We're still analyzing the data, so we'll see how that goes. But I just wanted to show that our technologies are very much related to one another as we go along. And we can use them in different ways. The last thing I wanted to describe was our scalable manufacturing. One of the things that we saw unable to get things out of the lab was that it was hard to produce. So we've had lots of newer students along the way have been working on this. That initial device that I showed you from 2019, really cool, pretty low cost, took a lot of parts. Most of the expense was in the commercial lateral flow test that we bought, so it could be reduced. But the real challenge was assembling all of these together. These were assembled with some very patient graduate students with tweezers. And that is not a manufacturing process. Graduate students are underpaid, but it still is not an efficient way to do that unless we wanted to break their hearts. So we worked on how to redesign this, and we redesigned it thinking about what needed to happen, what were the core components, and it's down to 6 parts. So the lateral flow strip is still there. It's still the most expensive thing, but we used a little thermoformed well that could hold the liquid rather than all of those back end pieces. And then we could align everything in a single row. We also looked at ways to reduce the electronics involved in controlling this. So if you think about self-regulating heaters, you can think about your car seats in newer cars. You can flip a switch and it gets up to a temperature without burning your body. And that's because these are positive temperature coefficient heaters in your car seats, and they can get up and hold a single temperature. So we went and printed some of these at a much smaller scale, and were able to control them up to anywhere between 55, 60, 65. And that image in the middle is showing that center point at 81 degrees. And we're able to hold it for at least 25 minutes. We did it for a full hour and showed that we could eventually get ourselves up to that 65-degree temperature in our liquid reaction, which sits above the heater, and that we could use these self-regulating heaters to run our RT lamp assays and then put them on the lateral flow strips. And you can see that we get a positive 2 lines yes when we put our either a control heater or underneath the PTC heater. That's our self-regulating. And they come up with very similar results. So that's exciting. And we can bring in that process automation there. The other aspect is, instead of tweezers, can we design something that could be built anywhere in the world and be used by other small labs or other manufacturers that are getting up and running? So we started by modifying a $300 CNC device that can drill cool patterns, and in moving it into a pick and place machine that can pick up and move our parts and pieces. We 3D printed some stuff, which is always fun for engineers, and we changed out some components and reprogrammed it. And then we now have this device that has a vacuum attached to it, run by an Arduino. And if I can get this little guy to run, you can see that it's picking up and moving the pieces and setting them back down as we go. We've made some progress since then. It no longer stabs our lateral flow strips, but this was the very first time we got it working. We were really excited. And you can see that we were able to assemble all the different components, including the wax valve on top of our lateral flow strip. And so things are moving along. The next thing we want to do is take this back to our community health workers and do some clinical sample testing again and repeat that iterative engineering process. So with that, we're hoping to get to an accurate, accessible testing for the whole community. I want to thank all of the people that have worked in the lab along the way, from the postdocs and the research scientists to the graduate students, the alumni, many undergraduates that have come through and rotated, and a number of them on our publications as well. Our collaborators, especially Dr. Rodriguez, who's taught me so much about equity-centered design, and our Indiana HIV aid organizations and clients who have really given us all kinds of feedback, as well as Dr. Stencio and Odari and Kinzer Ursum and Rice and Worley and many others. Our funding sources along the way that have contributed to different aspects, and you all for taking the time to listen today. So thank you very much.
Thank you so much, Dr. Linnes. Wow, how interesting. So many parts going into this process. Well, I'll start by asking the first question, which relates to that, which is as you go over something for so many years and are developing, I can imagine there's things along the way that change. And one of the things I think about is where are the extreme points of care can change with time. How does the climate change? So therefore your wax strips are melting as they go overseas, or expiration of the gel test. So all these things I'm thinking about how you probably had to pivot multiple times. I was wondering if you could tell us a little bit more about that.
Yeah, and I think the whole process is a learning process all along the way. I always think about the PowerPoint science design of our little strip that was going to be all in one row, and it was great. It was beautiful in my head in 2015. And then in order to get it to function, in order to run, we ended up having to over engineer a bunch of parts and put all these angles in and all these extra parts and pieces and layers to get it to just work. And then from there, um, once we have something functioning, we can then simplify it back down again. And I think that we wanted to try and keep it simple initially, but I think it's an acceptable way to go to say what do we absolutely need to make it work, and then what are the minimum components. And we did find, yeah, along the way, working with Dr. O'Dary, like, oh, yeah, these don't function, and the valves mostly worked. I think it was the proteins that needed a little more stability, and so we have a whole other project on lyophilizing and understanding from so much about vaccines is well known and those complicated mixtures, and so little is known on the diagnostic component side and drying things. It's again very empirical. They throw a bunch of different recipes at it, they get one to work, and then they move on. And so I have a PhD student who's really excited to understand those fundamentals. So we end up with lots of side projects along the way.
I'm sure, and I can imagine some of those side projects end up being other good products at the end as well.
Exactly. And it's taken us in, all those different directions with now we've got a protein test for the cervical cancer, which we had never thought of originally. And I didn't expect to doing much of anything with proteins, but we're working on that as well. And we have new collaborators. And I think the fun part about being in academia is we can take these side paths, as opposed to when folks are in a company, you really need to try and focus on getting your one thing done. So I enjoy the freedom that this provides.
Absolutely. My other question relates to the rapidity with which labs or places like yours had to develop COVID tests, because what I'm hearing, of course, is many, many years of dedicated time, but then suddenly we need a COVID test now, a home test. So can you talk a little bit more about that?
Yeah, I think that developing COVID tests was an exercise in what can be done if you do focus. Like if everybody puts all of the resources into one thing, it was really impressive how fast things got up and running. And one of the things that probably could have been done better was better collaboration, because there was a lot of reinventing the wheel, like right next to each other. So my lab was doing something, and then months later, I realized that a coworker literally across the street was also developing a very similar COVID test. And if we'd have thought about it, we could have, shared assays and used the learnings that we had along the way. And then I went to a conference a year or two later, and yeah, there were 30 other people who all had a very similar experience, not to mention all of the companies that want to be the first to get there. But under a public health emergency, I think sharing resources is absolutely something that can be done better. And next time we do need to do better. We've learned so much, but it did help to get a lot of technologies that were close to being ready to commercialize. That injection of effort and funds and support really got some of the stuff over the barrier. And there were some nucleic acid tests that ended up commercialized. not all of them, the companies have survived, but there was a lot that went into it, and then the learnings that came out of it have, I think, changed a lot. So
Very interesting. Yes. Let's all work together on a problem. That's what I'm hearing. I
yeah.
have a question from Dr. Stryker, and thank you so much for talking a lot about HIV, being that it was World AIDS Day this last week. So it's very helpful for us to think more about that as we try to uh, solve that problem. So Dr. Stryker asks, how important your end users find that HIV quantification matters when funders only care about detectable versus undetectable?
Yeah, it's been really interesting. I was on a really cool call with community organizations that a webinar that the NIH ran, and it was so variable, the needs of different organizations, different individuals, different parts of the country. Some folks were talking about they're still at the stage where they're trying to get the community to recognize that this is a real problem, and they feel like they're stuck in the 1990s. And others are working with people who are empowered and they're taking control of their health, and they want to be able to quantify themselves for their own viral load monitoring to know that they are safe, and that they think that they do have the education and the understanding of the disease to make those decisions. And so I think like that variability within the US, much less thinking about rest of the world, makes it really hard to design any one thing that could solve all the problems. I think that there's going to be different solutions for different users. And yeah, one of the discussions we had was what is undetectable? Because when we started our project, undetectable was under 1,000 copies per milliliter, because that's what the laboratories could do. Now, I think the WHO says under 200 copies per milliliter is undetectable, which means negligible risk of transmission to anyone. But some of the labs can do 20 copies of virus per milliliter, which is really different. And then, can we ever do that at a point of care setting? I don't know if we can get there without taking large volumes of blood, which requires a phlebotomist, which then brings you back to a higher resource options. So yeah, I think it's going to take different levels of technology for different users. And some of them will want and will benefit from the quantitative technologies, and some of them will benefit from just having something.
Right, something better than nothing at some levels, especially as you're talking about some of the extreme points of care, where there isn't anything offered. So I'm thinking that those extreme points of care often change, where you're looking, who needs something. And so how do you keep up with that, with who needs what? And maybe that's,
Yeah,
yeah.
you mentioned that. That's a really good point. I think that for us, we are learning about new extremes as we go. Every time we talk to somebody who has a different perspective, can tell us, oh, our community organization works in these settings in rural South Dakota, where we work with indigenous populations who have these available resources and not those resources. Your work in Indiana gives you some perspective, but not all the perspective. And so trying to gather as many different data points as we can. When you do community engaged work, it's really important to actually be in the community and have somebody as a source and a point of contact that's not just a Purdue professor flying in, asking questions, and then running away. That mostly just destroys trust. So we try and be really careful with building partnerships of people that we know are going to be there and are going to be there long term, and try and make our time or their time spent on something valuable for them as well, so that we're not just taking from the process. But yeah, it's a struggle, and every time we learn about a new place, I'm excited to learn about the new issues and challenges that we can make sure to build in solutions for.
Well, wonderful. Thank you, Dr. Linnes. I don't see any other questions here today, so we very much appreciate your time. And yes, anytime you're coming through Madison, you have a rain check to have cheese curds, time on the terrace, whatever it might be that you would enjoy. So thank you so
That would
much.
be fun. Thank you.